அந்த ஒன் நோட்ல அப்புறம் நான் அந்த சிட்டி பேங்க் லாகின் உங்களுக்கு தரேன். நெக்ஸ்ட் பெட்டர். பட் அந்த இன்னும் உள்ள ஒரு சளி எங்கேயோ இருக்கு. அலம்பிக்கு சரி, அவனை நான் அப்புறமா உங்களுக்கு வீடியோ காலா இல்ல கூப்பிடுறேன்.
நீங்க என்ன கிழமை சொல்லுங்க. சனிக்கிழமை அன்னைக்கு சும்மா அதுக்கு
சரி, நீங்க தேர்ஸ்டே கொண்டு வர சொன்னீங்க. போன தேர்ஸ்டே அவனை காமிச்சேன். 1 வீக்கு எழுதினேன் அந்த மருந்து எல்லாம். சாட்டர்டே கூட்டு வரட்டுமா? சரி,
அநேகமா மருந்தெல்லாம் நிறுத்திட வேண்டியது. வெறும் அந்த இதுதான் கான்டாக்ட்
இப்போ மாட்டேன். நீங்க வந்து ஆகுமெண்டன் அந்த டிடிஎஸ் ஸ்போர் வெட் காஸ்ட்
அந்த 3 பாட்டில் ஆச்சா 2 பாட்டில்?
2 பாட்டில் தான்.
ஏற்கனவே மார்க்ஸ் ஒரு 5 நாள் கொடுத்துருக்கோம். இன்னொரு பாட்டில் ஆகுமெண்டன் டிடிஎஸ் கொடுக்கறதுனாலும் கொடுக்கலாம். ஏன்னா மொத்தம் 15 நாள் 5 நாள் மார்க்ஸ் கொடுத்துட்டோம். 7 நாள் இப்போ ஆகுமெண்டன் ஆயிடுச்சு. இன்னொரு பாட்டில் வாங்கி
இந்த பாட்டில் இன்னொரு ஒரு நீக்க நாளைக்கு வரும்னு நினைக்கிறேன்.
வரும்னா
முடிக்கிறேன்.
முடிச்சுட்டு சாப்பிட பார்த்து
சொல்றேன். பாட்டில் பார்த்து இந்த பாட்டில் முடியறது 2 நாளா அதை முடிச்சிருக்கலாம்.
தாராளம்
14 நாள் இல்லைன்னா வாங்கிக்கிறேன். இந்த வருஷம் அப்ப சரமா வந்துட்டு நீங்க இதெல்லாம் போட்டுருக்கலாம். மாட்டலாம் போல இருக்கு. அதான் அந்த ஸ்குவாட் வந்து ப்ளீச்சிங் பவுடர் எல்லாம் போட்டு எல்லாம் அப்படியே ரோட்ல நின்று இருக்காங்க.
ஓவர் டூ பண்றாங்கடா. அதாவது கொரோனா பாசிட்டிவ்னா கொரோனா வியாதி இருக்குன்னு அர்த்தம் இல்லை. வைரஸ் அவன் உடம்புல நுழைஞ்சிருக்குன்னு அர்த்தம். இப்போ நம்மளோட மொத்த கண்ட்ரியில எல்லாருக்கும் இந்த ரேபிட் ஸ்கிரீனிங் டெஸ்ட் பண்ணி எவ்வளவு பர்சன்டேஜ் ஆஃப் பீப்புளுக்கு அதுல எதிர்ப்பு சக்தி வருதுன்னு பார்க்கணும். 40% பீப்புளுக்கு எதிர்ப்பு சக்தி வந்துருத்துன்னு சொன்னாக்கா அதுக்கு பேரு ஹெர்ட் இம்யூனிட்டி. அதுக்கப்புறம் அது நம்ம கிட்ட வேலையை காமிக்காது. இப்போ 1989 டெங்கு வந்தது வைரஸ். 100 குழந்தைக்கு 20 குழந்தை செத்து போயிடும். இது ஃபார்ச்சுனேட்லி குழந்தைகளை பாதிக்கல, பெரியவாளை பாதிச்சிருக்கு. டெங்கு மெயினா குழந்தை எல்லாம் சாவு நிறைய இருந்தது. கோல்டுக்கு கூட. ஹலோ,
unmute them again.
Good morning, sir.
very good morning, Abhijit. How are you?
Yes. Yeah, good.
Yeah,
So, yeah, we are all set. At 11, we will start.
sure, sir.
Yeah.
We have about 7 minutes more.
Yes.
Yeah.
Your voice is also perfect. It is very well.
Voice is perfect. Very good.
Yeah.
Very good.
And we will take the questions. So, how do you say? I take the questions and you will answer, or you want to?
You can take the questions and tell me. You will be seeing it on your screen.
Yes, I will be seeing it on the comments link, alembicpeo.com, which needs to be refreshed. So people post lot of comments and questions also, both.
Okay.
So some of the speakers say that they personally want to take it. But if you are okay, I'll take the questions.
Absolutely, no problem. Both ways, I have no problem.
Okay.
I thought because I'll be concentrating on the questions and answers.
Right.
I may not get into the mechanics of reading it and then decide.
Right. That absolutely makes sense. Right.
Yes.
Right.
Yes.
Absolutely.
Yeah.
Right. So I'll just be with that website also, which has to be checked.
We will start in 3 minutes, sir. 4 minutes, sir.
Sure.
हाँ जिग्नेश भाई आप एक बार once you type a message not start, then I will start.
Okay.
Just, at around 11 o'clock आप जब message करोगे ना, then I will start.
Okay.
I'll just mute for the time being.
Sure, sir. Sure. So, இப்ப என்ன ஆகும்ன்றத உனக்கு நான் சொல்றேன்.
Abhijit sir, we are about to start.
Good morning, doctors. Warm welcome from Alembic Maxis team to today's Pedia Expert Opinion. It gives me immense pleasure to welcome Dr. V.V. Varadarajan, who is our speaker today. Dr. Varadarajan is Director of Pediatrics, Rainbow Children Hospital, Chennai. He is a Senior Visiting Consultant at KKCTH. And the subject he's going to speak today is all that wheezes is not asthma. So it's a very pertinent, clinically pertinent topic. So I now hand over to the session to Dr. V.V. Varadarajan. Thank you.
Good morning, Abhijit. Good morning, doctors. Welcome to all of you. I thought instead of boring you with much more information on COVID-19, all of us are saturated or super saturated with COVID-19. We will give a talk on a subject which is very close to my heart. I'm sure it is also to your heart, because very frequently when we are practicing, the parents ask a question when we are treating a wheezy child: is my child suffering from asthma? This is the question frequently asked by the parents, and we sometimes find it difficult to answer that question. So I thought all that wheezes need not be asthma. We must be keeping our eyes open, wide open, and looking at things which distinguish asthma mimics as well as comorbid conditions which can coexist with asthma or mimic asthma. So that is the purpose of this talk. And at the end, I would like to get interactions. Abhijit sir will be the mediator, and you can type your questions and he will throw your questions to me, which I will try to answer at the best of my ability. Let's go on to the presentation. When we see a child with wheezing, the first question that we should ask the parents is that, is it really a wheeze? Because many of the parents mistake noisy breathing, which may be due to an adenoidal enlargement or a stridor, for a wheeze. Stridor is predominantly an inspiratory sound, can also be an expiratory sound, but wheezing is predominantly an expiratory noise. And the age of onset. When the child has wheezing at a very young age, we have to be more alert to the possibility that it may be an asthma mimic and may not be a true asthma.
Sir, share the
Yes.
presentation.
Pardon?
Presentation, share.
It is not there? Oh,
No.
sorry. Sorry. Are you getting the voice?
It's breaking, but
Yeah, I'm getting it. Can you start, please?
Are you getting it?
Yes, yes.
Yeah. So what is the age of the onset? If it is very young, we have to be more alert to think of the possibilities of an asthma mimic. And when it is sudden, we have to think of the possibility of a aspiration, foreign body aspiration. Similarly, while we are auscultating, is it bilateral wheeze or is it localized and unilateral? And the cough or the wheeze, is it chronic and persistent, or it comes once in a way and goes? To differentiate the phenotype of an asthmatic child. And is it related to feeding, to think of GERD, whether it is associated with infection, to think of an episodic WHEEZER associated with a viral infection. Is there a family history of asthma or a personal history of atopy in the form of the allergic rhinitis or atopic dermatitis? And are there any unusual features in the child, like a murmur or a clubbing or a failure to thrive? So let's go step by step in this. The congenital problems which can mimic asthma, some of them are tracheomalacia, cystic fibrosis, congenital heart disease, primary ciliary dyskinesia, and the bronchopulmonary dysplasia, which may not be truly congenital, may be seen in a child that is ventilated for a prolonged period of time. Then we have to think of chronic rhinosinusitis, foreign body, if it is acute. Aspiration syndromes, we have to remember two things. One is the gastroesophageal reflex. The other is the postnasal drip, which you can see in a sinusitis. And a vocal cord dysfunction, which is very often mistaken for asthma. Some of these conditions may mimic asthma, and some of them may coexist with asthma. So we are going to have about 10 case scenarios giving you all these asthma mimics and comorbid conditions. So let us go one by one. Now the case scenario 1, where a 3-month-old male infant is brought with history of a cold and runny nose or sneezing for a few days, 2 to 3 days. And when you examine the child, it is tachypnic with subcostal and intercostal retractions. And if you are in an emergency room and you check up the SaO2, the child is hypoxic. And very many times you hear a bilateral sibilant wheeze. A sibilant wheeze is a high-pitched wheeze, which arises from the narrowed bronchioles. I don't know how many of you listen to the flutists. The South Indian flutists play a sibilant wheeze, whereas if you have a thick flute like Hariprasad Saurashya, you will hear a sonorous wheeze, as you hear in a, which may be a monophonic wheeze, as you hear in a tracheomalacia or tracheobronchomalacia. And in this child, there is no family history of asthma, and you are nebulizing. The child is not showing a very good improvement with nebulization. And as the child is hypoxic, you are giving oxygen for this child, and the distress seems to be a bit settling down with oxygen. Needless to say, it is child's play for all the elite pediatricians like you that the X-ray is showing bilateral hyperventilation, and the majority of instances of bronchiolitis is because of the respiratory syncytial virus, though the para-influenza and the metapneumoviruses and the adenovirus can also play a role in some of them. Majority of the bronchiolitis is due to the RSV infection, and the viral infection produces an enlarged thymus, which gives rise to the famous bow sign, which you can very well appreciate in the right side of the heart border. Merging with the heart border, you can see the thymus. Usual management is to keep the oxygen till the SaO2 is above 94 and you give humidified oxygen, which is very important. Generally, if you give a trial of nebulization.
Sir, sorry to disturb you. Sir, your voice is breaking. Can you just speak slowly, so your voice is being clear?
Okay.
Okay.
Is it okay now?
Yes, sir. It's okay.
Yeah. The humidified oxygen is the hallmark in the treatment of bronchiolitis. If you see, sometimes there's a family history of asthma, and we tend to nebulize these children with levosalbutamol. If one nebulization gives relief, people consider that you can continue it. But if one nebulization with levosalbutamol is not giving enough relief, then probably there is no point in continuing it. If you are suspecting the syndrome of inappropriate ADH secretion because of the stress, restrict the fluids to about 60 to 70%. And nebulization with 3% sodium chloride is supposed to decrease the secretions and preferred by some to levosalbutamol. Monitoring the vitals and the oxygen saturation is of paramount importance, and nebulization with beta agonists is controversial. Some people have used steroids with adrenaline, the combination of adrenaline nebulization with steroids, and claim good success, but again it is controversial. So the hallmark will be giving humidified oxygen, taking care of hydration, and taking care of hypoxia. Now we will move on to the case scenario 2. It is a 9 months old female infant which has come with history of discrete episodes of wheezing, each time with fever and an upper respiratory infection. The child is well in between the episodes, and there is no personal history of atopy like atopic dermatitis or family history of asthma. Which is your diagnosis? You can choose one among the following. I'm sure all of you will be choosing B, which is the condition that the child has got, episodic WHEEZER, where the episode is induced by a viral infection. A multi-trigger WHEEZER will have wheezing even without a viral infection and may have wheeze in response to exposure to various allergens, which may be a cockroach allergen or a cat allergen or a pollen. So there are no unusual features in this child for us to suspect asthma mimic. Episodic WHEEZER is usually managed. The acute episode is managed by treatment with oral or inhaled bronchodilators. Whereas in the long-term management, if the frequency of the episodes are very much, probably we can consider a short course of leukotriene receptor antagonist like the montelukast, which is the safety of which is established in children. But there is no role for inhaled corticosteroids in these children unless their phenotype changes from that of episodic WHEEZER to a one with multi-trigger wheezing. We will move on to the case scenario 3. Here we have a 1.5-year-old girl brought with sudden onset of respiratory distress. Child is having hypoxia. You can always make out clinically the hypoxia by these children behaving in a restless manner. And the respiratory distress is increasing in severity right in front of your eyes. And you go back and ask for any history. Was the child eating something when the child suddenly developed this following an episode of choking? Then the mother comes out with the history. The child has been eating ground nuts. And you are auscultating the child and you are seeing the wheeze on one side. In this child, it is the left. In this, you will see the hyperventilation and the obstructive emphysema on the left with a slight shift of the mediastinum to the opposite side, which is the right side. So, in such instances, what should be your next method of investigation? Will you straight away go for bronchoscopy? In some instances, you may not have the history of choking given by the mother. A good expiratory chest film. See, the foreign body, which has gotten usually a vegetable foreign body, which is not visualized in the plain skiagram, may obstruct the bronchus and may function as a bell valve. And this will result in entry of air into the left lung, but will not exit, resulting in the unilateral obstructive emphysema on the left side. You can take a lateral decubitus film, or if you have facilities for a fluoroscopy, you will see that the mediastinum, the obstructed lung, partially obstructed lung, is not able to expel the air and reduce its volume, and you will see the mediastinum shifting to the opposite side. Then you get the pulmonologist to do the bronchoscopy, which is not only diagnostic but also therapeutic in nature. You will see in this child it was the groundnut which was responsible for the acute respiratory distress with unilateral wheeze. So we have almost seen 3 case scenarios now. We will be getting into the 4th one. This is a 7-month-old male infant. There is history of recurrent wheezing and cough. The mother says the child is coughing, and at the end of it vomits and again develops severe wheezing. And sometimes, because in a 7-month-old child, the vomiting will also be taking place through the nostrils. Probably the child has noisy breathing also because of the partial obstruction of the nares. And the child has incessant cry and arching after the feet, what we call as the Sandifer syndrome or posturing. There is no family history of atopy. When everything is so simple and straightforward like this, it is not a big job to diagnose a gastroesophageal reflux disease. But we have to differentiate the gastroesophageal reflux and a gastroesophageal reflux disease. Gastroesophageal reflux is physiological. It is present in most of the children up to the age of 9 months when they assume an erect posture and thereafter the vomiting goes. On the other hand, a gastroesophageal reflux disease is one where the lower esophageal sphincter is lax and increased pressure on the stomach, which may be the result of coughing, which temporarily increases the pressure inside the stomach, which overcomes the lower esophageal sphincter pressure, and thereby there is acid reflux. And this acid reflux stimulates the vagal endings in the lower end of the esophagus. The vagal endings in the lower end of the esophagus is one thing which is parasympathetic, and parasympathetic stimulation will result in bronchospasm. That is how the child gets into a vicious cycle, and the child starts coughing again, which again increases the intra-abdominal pressure and the reflex. We have so many tests now to diagnose a gastroesophageal reflex disease. And the chief among them, which is affordable and easily done, I would consider, is a barium swallow or a barium study, deglutition study, which will also help us to know the movement of the peristalsis of the esophagus. Well, a milk scan or a gastric CT scan may not give the anatomical details, so we may miss an associated hiatus hernia if it is there. 24-hour esophageal pH monitoring is one thing which is a little bit more invasive and may not detect alkaline reflex, only acid reflex. So if at least more than 5 to 8% of the time monitored, if the pH is less than 4, we can come to a diagnosis of gastroesophageal reflex disease. Endoscopy is more invasive. And there are some experts who can look at the ultrasound at the GE junction and make a diagnosis of GERD. So this is how it looks like in the barium swallow and fluoroscopy. You'll see the reflex taking place from the stomach. See, we have already discussed this. Barium swallow does not detect pathological reflex from physiological reflex. Milk scan doesn't give anatomical details. 24-hour pH monitoring may not detect the alkaline reflex. Endoscopy is invasive, and you may not have in every place a specialist ultrasonologist who can find out the reflex from the GE junction. Much more a pulmonologist do a BIL for looking for lipid-laden macrophages. So I would like to have a word before I move on to the next case scenario. Whenever you see a young infant where you are having difficulty in controlling the wheeze, please think of comorbid GERD, which may be there, and with your domperidone and a PPI, proton pump inhibitor, the symptoms will come under control, not only the GERD symptoms, but also the wheezing will come down. Now, we are getting on to the case scenario 5. It's a 10-month-old male infant. Noisy breathing is there right from birth. So sometimes, in their own colloquial vernacular, they will say, well, how long is the noise is there? Right from the time of his birth, sir. So recurrent respiratory infections history is there. And at times it is also associated with fever. And there is also a history of repeated nebulization. But there is no complete response to the nebulization, and there will be only a partial response to nebulization. And there can be a past history of admission also. In this child, it is there. So what do you think of, having discussed earlier the causes of comorbid conditions as well as the causes of asthma mimics? We must think of from the history of noisy breathing, it may be a sonorous wheeze. And some of these children will have a tugging in of at the suprasternal region. If they have a very pliable rib cage, you will see the entire rib cage moving also. If the tracheomalacia or the laryngomalacia is very severe. So cystic fibrosis, we don't have the history of malabsorption or failure to thrive in this child. Episodic WHEEZER, sometimes there is history of fever. We have to bear it in mind. Multi-trigger WHEEZER, there is no family history of atopy or personal history of atopy. So I would like to bet on the laryngomalacia and tracheomalacia as a diagnosis in this child. The normal trachea has cartilaginous rings, and you will see, as on this side, you will see them in a very circular fashion. But when you have tracheomalacia and do a bronchoscopy, if you see a patellus horizontally compressed or a triangular trachea, you can think in terms of tracheomalacia. We must know the tracheomalacia or a bronchomalacia can be a primary one, which is due to the absence of the cartilaginous rings, or maybe secondary to some of the conditions, like a tracheoesophageal fistula. You should also ask for history of any operations in the child. If it is there, you can think of secondary. Otherwise, we have to think of vascular rings also. Double aortic arch, abnormal origin of the innominate artery, are some of the conditions which can produce not only dysphagia, lusoria, but also you will see the secondary tracheomalacia or a bronchomalacia. There are only two things which support the trachea and bronchi, and the bronchomotor tone is one thing, other is the cartilaginous rings in the trachea. And when you use the beta agonist, the bronchomotor tone is reduced. So you may have aggravation of the symptoms in some cases. Some of them may respond because of the coexistent asthma. But if it is pure and simple tracheobronchomalacia, then ipratropium will be the drug of choice rather than beta agonist, which can aggravate the symptom in some of these children. In fact, I had a 7-year-old boy who came to me with recurrent pneumonia, almost on the same side, right side. And bronchoscopy showed bronchomalacia of the right lower lobe bronchus. And the advantage in tracheobronchomalacia is these children, when they are young, the symptoms are very looking dramatic and dangerous. But as they improve, by about 3 to 4 years, many of them do well. In case scenario, we'll move on to the next, which is the 6th one. A 3.5-year-old boy has been brought with recurrent wheeze and episodes of wheezing are not associated with fever. And there is history of repeated nebulization. Father is a smoker. He smokes at home. And there is also a family history of asthma. The grandmother is a known asthmatic. And this child has been hospitalized twice and remains symptomatic even in between the attacks of wheezing. Does this history ring any bell? This is the X-ray where we have a bilateral hyperventilation with increased bronchovascular marking. So, needless to say that he fits in with the diagnosis of a multi-trigger WHEEZER. So, which one will be the appropriate in the following. Is it an oral beta agonist alone or an inhaled beta agonist? Is it a long-term trial of the leukotriene receptor antagonist or an inhaled low-dose corticosteroid or a moderate dose inhaled corticosteroid? The management in a multi-trigger WHEEZER will be a trial of inhaled corticosteroids, 400 microgram per day for about 12 weeks we can give. The safest will be a budesonide, which is the simplest, has good first pass effect. Many of the drug is removed by the liver during any swallowed aerosol. It will be removed by the first pass effect. Significant improvement is there in 12 weeks. It is likely to be a multi-trigger WHEEZER. If there is no improvement, and this gentleman is a candidate for asthma. If there is no improvement, look for alternative diagnosis again. And if there is recurrence of symptoms on stopping, reintroduce inhaled corticosteroids. Alternative, another poor alternative will be a leukotriene receptor antagonist. Studies have shown that in these type of children with a family history, the inhaled corticosteroids improve the lung function by at least 10 to 15%, whereas leukotriene receptor antagonists improve the lung function only by 5 to 7.5%. Now we are going to move on to the case scenario 7. It is a 6 months old female infant admitted twice for acute severe asthma. This child was referred from Salem for further management because twice it has got into ICU, treated asthma, shown a good improvement, and then discharged, but again only to get readmitted. And there was no family history of atopy. Surprisingly, this child was thriving well. It was not a failure to thrive. Child was thriving well. What do you see in this X-ray? Apart from the hyperventilation, do you see normally the trachea is slightly to the right, but you see here there is a beautiful bend, shift of the trachea to the right in a very significant extent. So this child had hyperventilation. We initially thought of cardiomegaly. There was no diaphragmatic hernia. It was only a shift of the trachea to the right. We went and did a CT in this child, and the CT confirmed the compression of the right main bronchus at the level of the carina, and CT confirmed the bronchial cyst. We called the cardiothoracic surgeon and the pediatric surgeon, and they removed the cyst, and the child was subsequently asymptomatic. We followed up the child for about 2 to 3 years, and it was doing well. A bronchial cyst need not present at birth. Generally, the problem takes place before the 16th week of intrauterine life, where the tracheal bud and the bronchial bud from the foregut diverticulum actually develops into becomes cystic and develops into the bronchial cyst. It can present when it enlarges sufficiently to compress on the adjacent structures. In this case, probably child, it was the bronchus, and thereby producing wheeze. or it can present with recurrent infections when the when the bronchial cyst gets infected. So whether it produces respiratory distress with compression or not, a bronchial cyst has to be removed. We will move on to the next case scenario. It is a 7-year-old girl has been suffering from recurrent respiratory tract infection since birth. History of repeated courses of antibiotics and history of repeated nebulization also. And needless to say, in our country, child has received ATT at the age of 3 years also. And on examination, the child was having a weight of 14 kilos, which is far way inferior to what a 7-year-old girl should weigh. And on examination, there was a mild clubbing also. So what will be your diagnosis? A chronic persistent asthma or bronchiectasis or cystic fibrosis or a congenital cyanotic heart disease. Child did not have any cyanosis and there was only clubbing. There were rales, but not very coarse to qualify. I wouldn't blame if any of you think of bronchiectasis in this child. And cystic fibrosis is a strong possibility. When we come across a child like this with unusual features, I think we have to rule out cystic fibrosis and ciliary dyskinesia. We have to ask for history of consanguinity because both cystic fibrosis and ciliary dyskinesia are disorders which are autosomally recessively inherited. And we have about 1,500 mutations, though the commonest is F508 for cystic fibrosis. We have about 18 mutations for ciliary dyskinesia. And what will be our next step in evaluating these children? We should ask for history of a previous sibling death, which invariably will be there in a child with cystic fibrosis. We must ask for history of any meconium ileus or a meconium plug syndrome in the neonatal period. History of malabsorption. The ideal way to diagnose will be showing at least 2 elevated sweat chloride concentration, 60 milliequivalents per liter. Above that, 40 to 60, we have to repeat. If you see them in the newborn period, of course, immunoreactive trypsinogen estimation will be of help. If there is evidence of malabsorption, then elastase, pancreatic elastase in the stool. So the abnormal nasal epithelial potential is a experimental tool, not routinely done. But nasal epithelial cilia study under the electron microscope to look for the presence of the cilia and the frequency, the frequency with which the cilia are beating may also help. So unless we look for unusual features in an asthma, we cannot detect these asthma mimics. We'll move on to the next case scenario. And a 10-year-old boy, he has been treated as persistent asthma. He has received almost 400 micrograms per day for 6 months, inhaled corticosteroids. and treating pediatrician was well versed with the management of treating children with asthma, have checked the technique of inhalation, which was found to be correct in this child, and he has stepped it up to 800 micrograms with addition of a long-acting beta agonist like, salmeterol for about 6 months. And then also there was no improvement. So he thought of an uncontrolled asthma and referred the child to a pulmonologist. In this child, there was evidence of persistent cough along with rhinitis, and there was also mouth breathing and snoring. We have ruled out improper technique and inadequate dose is not there. It has been stepped up to the maximum permissible dose in a 10-year-old. To think of alternate diagnosis, we do not have any murmur or clubbing or failure to thrive. So we have to think of a comorbid condition in this child, which was there because the child had mouth breathing, persistent rhinitis, sneezing. So we took an X-ray neck to look for an enlarged adenoids, which was there, compressing the nasopharynx, resulting in the mouth breathing. In fact, this X-ray is not taken well. When we take an X-ray neck, we should ask them to open the mouth, ask the child to breathe and then take. That will show the nasopharyngeal component of the airway very well. And here we have evidence of bilateral maxillary sinusitis. Whenever you have a child with wheezing with maxillary sinusitis, go back and ask for history of ear discharge, and you have to think of ciliary dyskinesia also. But this is nothing but, this child turned out to be nothing but post-nasal drip, which has been happening because of the sinusitis. Unless you treat this sinusitis, the child's wheezing is not going to come under control because the post-nasal drip will result in the right main bronchus being in a line with the trachea, will result in the production of an infiltrate in the right base, and that will result in recurrent respiratory infection with wheeze. In these children, if you take an X-ray chest, you will always see an infiltrate in the right base. So, what are the comorbid conditions that are associated with asthma? Allergic rhinosinusitis, which is usually present with sneezing in the morning, a runny nose or a blocked nose, and may require addition of a bedtime antihistamine. And if it is an older child, probably a third generation non-sedating antihistamine like fexofenadine. And in severe cases of allergic rhinosinusitis, treating the child with weekly azithromycin steam inhalation and using fluticasone furoate may be the ultimate thing which will give relief from the allergic rhinosinusitis. Adenoidal hypertrophy may be responsible for frequent ear infections. Also, gastroesophageal reflux disease, we have seen a few slides back how to manage. They may present with recurrent vomiting. Use of theophylline and oral beta-2 agonist can aggravate the reflux disease. So esomeprazole is the safest PPI which we can use in young children. And then obesity may also be a comorbid factor because of the presence of adiposity in the omentum as well as in the abdominal wall. The diaphragm may be pushed up, and that can result in increasing respiratory difficulty in these children when they get the acute asthmatic attack. Now we are moving over to the last case scenario in this series. And this was a very interesting case which floored all of us. And we had to get the opinion of the pulmonologist and observe the child after admitting and then come to a conclusion. It was a 12-year-old girl. A known WHEEZER. She's supposed to be a volleyball player in school. She has been having wheezing for about 2 to 3 years, increasing in severity. That's what they said. They said whenever she comes from school, the moment she starts playing, she develops wheezing. And there is also a history of recurrent admissions. She has been treated as acute severe asthma twice or thrice. The symptoms which were reported by the parents included a tightness in her throat. She always complains at the onset of the attack, a tightness in the throat and a tightness in the chest. And she also reports, they also reported a voice change. They say that her voice is very squeaky. So we decided to admit her because on examination, we couldn't find anything. In fact, I couldn't hear any wheeze at all in her. So we observed her and we requested the duty postgraduate to observe whether she has any cough or sleep disturbance in the night. She slept very well and there was no sleep disturbance in her. So we were puzzled. Is it an uncontrolled asthma? Is it an exercise-induced asthma which gets aggravated only when she plays the game? But the parents were giving that a history that she was also getting the attacks whenever she was very anxious, nearing the exams, and whenever she gets anxiety, she gets so, which made us think of malingering. And the last happened to be the correct diagnosis, which was a vocal cord dysfunction. When you see vocal cord dysfunction, there are 3 groups of children in that. One who have spontaneous vocal cord dysfunction, another where the vocal cord dysfunction is secondary to exercise. The basic problem in vocal cord dysfunction is adduction of the vocal cords when the child takes an inspiration. So what they get is a high-pitched stridor, a squeaky noise, which the parents complained of. And this is followed by, see, if you take a group of 100 children, there is a paper by Weddingman and Doshi, which says that if you take 100 children with vocal cord dysfunction, about 52 of them will have exercise-induced vocal cord dysfunction. And in about 36 or 32 of them, you will have a spontaneous vocal cord dysfunction. And in about 8% of them, they may be coexistent. And they say 12% of children with vocal cord dysfunction can also have asthma. So it becomes a very tricky question. And your diagnosis can depend on, we can't do symptom provocation by inhaled methacholine or choline, so acetylcholine. On the other hand, spirometry can be easily done in a 12-year-old. And normally, we get a beautiful good inspiratory loop in the asthmatics. You will only have scalloping of the expiratory flow limb. And you see here, the FEV1 by FEC is not affected at all. It is 0.98. On the other hand, you see a flattening of the inspiratory loop of the child spirometry. So, which increased our suspicion, and with the help of a video laryngoscopy, which must be done in an alert and awake state, because if you are going to sedate the child, the vocal cords will be relaxed, so you will miss the diagnosis. This clearly established the diagnosis, which was confirmed by video laryngoscopy. So moving on to the management of vocal cord dysfunction, because there is an element of anxiety involved in these children. This particular child had anxiety, and at the time of exams, they were telling that she used to get more number of attacks. And then if you see, there is also reported in the literature, sexual abuse may be one of the causes for vocal cord dysfunction, resulting in anxiety. So we subjected this child to relaxation techniques and breathing exercises. And there was an element of exercise-induced bronchospasm present in this child. So we advised inhaled ipratropium 20 minutes prior to the child playing the volleyball. We educated the parents about the nature of the disease, told them there is no need to nebulize the child when the child gets acute symptoms, and speech therapy was also given for her. And over a period of a year, she improved. And profusely the parents thanked us. So coming to the last slide, I think, Abhijit, is it okay?
Yeah, it's fine.
We have about 10 minutes more. So I'll just give the take-home message, then we can take questions.
Sure.
Okay? Yeah.
Yes.
Younger the child, think of alternative diagnosis. This we must always bear in mind. And whenever there is a difficult to control asthma, think of mimics and comorbid conditions. In the younger child, think of GERD. In the older child, think of sinusitis, allergic rhinoconjunctivitis. And think of asthma mimics like tracheobronchomalacia and cystic fibrosis, ciliary dyskinesia. And remember the phenotypes of the under 5 wheezers, the episodic viral wheezer and the multi-trigger wheezer. And they don't live in watertight compartment. A child which was an episodic viral induced wheezer may become a multi-trigger wheezer over a period of time. Diagnosis of asthma is always clinical. Investigations are required only to rule out alternate diagnosis. Thank you all very much for a very patient listening. Now I think Dr. Abhijit will help me to take the questions.
Thank you very much, sir. Excellent clinical case scenario-based talk, covering almost the entire spectrum. So let's begin with the questions. Dr. R.K. Srivastava from Gorakhpur wants to know the differential diagnosis of coarse crepitations with off and on rhonchi.
I think we have to think of simplest of them, the bronchiectasis. And if you are going to think in terms of recurrent respiratory infections, in a cystic fibrosis child also, if there is coexistent malabsorption, failure to thrive, if you look at the pathophysiology of the cystic fibrosis, It starts as a bronchiolitis, bronchiolectasis, and then it goes on for bronchiectasis also. And a CT, if you are suspecting ciliary dyskinesia or cystic fibrosis, and if there is your suspicion of bronchiectasis is very strong, there is nothing wrong in taking a high resolution CT chest where the radiation will be less and we will be able to make a diagnosis. If it is associated with collapse consolidation or the child's asthma being very difficult to control, and you are strongly thinking in terms of cystic fibrosis, but the parents cannot afford genetic mutation studies, and your ciliary, your sweat chloride test is indecisive, probably a bronchoscopy in such children with aspiration of the BAL. If you look at the bacteriology of the BAL, you may be growing unusual organisms like the Pseudomonas or Staphylococcus or Burkholderia, which may indirectly give us the diagnosis of cystic fibrosis. So we have to think of these three conditions like just a bronchiectasis because of repeated respiratory infection. Second is cystic fibrosis. Third is ciliary dyskinesia. Recurrent ear infections, azoospermia in an older, probably adolescent, and asplenia, polysplenia, the occurrence of Carter-Jenner syndrome, absence of a frontal sinus or sinusitis with inversion, situs inversus, totalis, all these may point out a strong clinical suspicion of ciliary dyskinesia.
Dr. Uday Kumar from Arcot, he is a past PG student, and he is asking how is cough variant asthma different from the usual bronchial asthma?
This is a very good question, because many a times I will put it as CEA, cough equivalent asthma. See, when you have a spastic cough, which is more troublesome early in the morning, we all know that our bronchial diameter is very less in the early morning hours of the day and the middle of the night. That is why when we operate on the children who have asthma, the operation is usually scheduled for the evening, where the bronchial diameter will be much better to tolerate the anesthesia. The cough equivalent asthma is a clinical diagnosis. If you have a family history of asthma or a personal history of atopy in this child, the personal history of atopy may be in the form of an allergic rhinoconjunctivitis, or it may be in the form of an atopic dermatitis. So when the child was having severe eczema, doctor, very many times we will see the parents complaining like this. The child had severe eczema up to the age of 2 years, doctor, but then he recovered from this. Now this cough has come, what to do? So if you have the asthma predictors, like the child suffering from bronchiolitis in young age, or atopy when the child was an infant, and now the child is brought with cough equivalent asthma, your diagnosis of cough equivalent asthma is tenable. Please keep it as your professional diagnosis. Follow up the child and see whether the child gets into a multi-trigger WHEEZER and then subsequently a bronchial asthma. Till the child is 6 to 7 years, we are not able to do spirometry. And sometimes the spirometry also is normal in these children, because if it is above 80% FEV1 by FEC, we think that the child is not having asthma. So cough equivalent asthma is a good working clinical diagnosis. We cannot equate it with asthma. Follow up these children with a clinical suspicion that they may land up with asthma at a later date.
Dr. Ramesh Kumar from Devgar wants to know the importance of pulmonary function test in asthma.
In fact, way back in 2005, when I had bought a spirometer, I was very happy doing left and right pulmonary function test for children with uncontrolled asthma. The clinical correlation of the correlation of the clinical severity of asthma with the pulmonary function testing, because when you find out this FEV1 by FEC ratios, if it is more than 80%, no asthma, 60 to 80%, it is mild obstruction, and 40 to 60% moderate obstruction, below 40, severe obstruction. I compared the clinical severity with the severity given by the spirometry. There was absolutely no correlation. So the only thing that I can advise you to do is, though we take all precautions in discontinuing all the bronchodilators, at least the long-acting bronchodilators means we stop them at least 48 hours before. So in spite of taking all these precautions, still we find that these children, they may not correlate well with the spirometric grading. Many a times it is disappointing. So I switched over to, in my chronic persistent asthmatics, buying a PEFR and giving it to them, noting their personal best. Because some of these children are poor perceivers of their symptoms. They are not able to perceive their symptoms and report immediately. So the parents miss the bus. In such children, if we record the PEFR, and if the PEFR is above the 80 of their best, then it is a well-controlled asthma. If it is between 50 and 80, it is not, the control is not up to our satisfaction. Below 50, the child is a brittle asthmatic which can break down and need acute severe asthma management anytime. So they must meet the pulmonary. So I find in practice PEFR monitoring much better than spirometry in treating these children.
Dr. Sanjay Kumar Rathi from Dharan asks the role and efficacy of Montelukast in pediatric cough.
In pediatric? Cough. Again, if you are sure it is a cough equivalent asthma, see, if you look at the origin of leukotrienes, receptor antagonists. See, initially we had leukotriene inhibitors rather than receptor antagonists. The release of leukotriene itself was, like we had compounds like xylitol, but because they were inimical to the liver functions, which produce increased liver enzymes, they were not fell into disfavor. So, on the other hand, Montelukast is considered to be safe in children. In fact, I have listened to Dr. Price, John Price, telling that he has used it even for about 2 to 3 years without any problem in children. But we have to understand they have their limitations, because histamine, leukotrienes, interleukins, there are so many chemical mediators of allergy. So blocking only one, the mediator of allergy, is of no use. They are always inferior to inhaled corticosteroid. But in your case, your question was in cough. Yeah, if you are thinking in terms of cough equivalent asthma, there is nothing wrong in giving a trial of 8 to 12 weeks of Montelukast.
Okay. Dr. Sanjay Kumar Rathi from Itahari asks, does cetirizine or fexofenadine dry up secretions in the chest, and therefore should it be avoided in children with productive cough?
Could you repeat the question, sir?
does cetirizine or fexofenadine dry up secretions in the chest, and should it be avoided in children with productive cough?
See, we have antihistamines belonging to 3 generations. The first generation antihistamines, like your, phenyramine, chlorphenyramine, they all produce drying up of secretions. The second generation, like cetirizine, are not that capable of drying up the secretions, and more so with fexofenadine, which is a 3rd generation, and of course levocetirizine, which is also a 3rd generation. So the advantage of a 3rd generation antihistamine is not only they are devoid of the side effects of drying up of the secretion, but also they are devoid of the sedation, which is usually seen with the 1st generation antihistamines, and to a lesser extent the 2nd generation antihistamines. So 3rd generation antihistamines, if there is an associated allergic rhinoconjunctivitis, there is no harm in giving them.
Dr. Muzaffar Qureshi from Srinagar wants to know what is the incidence of bronchial asthma later in kids who have suffered bronchiolitis in infancy.
When we go through the Tucson study and other studies which have followed up children who have had the respiratory syncytial virus infection and bronchiolitis, 30 to 60% of them can go in for persistent asthma at a later date. Some of them quote about 30%, and a few others quote even 50%. So,
Dr. Sandeep Kaushik from Delhi wants to know which is better, intermittent nebulization or continuous nebulization in an acute exacerbation of asthma in the first hour in emergency.
In the acute exacerbation of asthma, what are the last part of the question?
Whether intermittent nebulization or continuous nebulization in acute exacerbation of asthma in first hour in patient presenting in emergency.
Yes. See, we are going to grade them by using the pulmonary score. If it is mild, we are not going to give continuous nebulization. 0 to 3, we are going to give pulmonary score. We are going to ask them to use the aerosol itself at home through MDI, 1 puff every 2 minutes for 10 minutes, 5 times. If the child is not getting relief with that, and if you find that the pulmonary score is between 3 and 6, you're going to give intermittent nebulization, say once in 20 minutes, and then reassess. And if it is a younger child, you're scared to use too frequently beta agonists, you can add on ipratropium at this stage. Whereas when it is a severe asthma, where the pulmonary score is between 6 and 9, and you're going to admit it in intensive care, then I think the need of the hour is a continuous nebulization.
Okay. Dr. Pradeep Bhattarai from Gandaki wants to know, in very young children where PFR is not possible, what can be the alternative and what will be the symptomatic management in laryngomalacia?
See, laryngomalacia, first I will come to the first part of the question. What was the first part of the question?
Younger children where PFR is not possible, what can be the alternative?
See, we go by symptom diary. In younger children, ask the parents to maintain a symptom diary. Ask them to find out how many good restful nights the child had, whether there is any bedtime cough. Secondly, is there any need to increase the use of beta agonists on an SOS basis? If it is an episodic WHEEZER and there is an increased need for the use of beta agonists, instead of using it 3 times a day, they have to use 6 times a day. Instead of 1 puff of levosalbutamol, they have to give 2 puffs of levosalbutamol. Then we know that the child is deteriorating. If there is a family history of asthma or a personal history of atopy, we are justified in introducing a low dose inhaled corticosteroid in those children. with respect to laryngomalacia, it all depends upon the grading of the laryngomalacia. You can always get the help of your ENT friend in doing an indirect laryngoscopy, video laryngoscopy. If it is mild, you just reassurance. If it is severe, probably no. Some people believe in giving calcium, but reassurance with instructing the parents to avoid aspiration, because many of these children have concomitant aspiration syndromes. So keeping the head end elevated, usually they settle down. A video laryngoscope will also rule out conditions like subglottic stenosis and hemangioma of the vocal cords, which can also give rise to a stridor. So, of course, needless to say, any posterior cranial fossa tumors or anal malformations can also give rise to stridor. So generally, a mild congenital laryngomalacia subsides anywhere between 8 to 9 months. If it is moderate to severe, they become all right by almost 1 year.
Okay. Dr. Shobha Chandran from Chennai wants to know, is fever a common presenting symptom in children with tracheomalacia?
No. Okay. Bacterial tracheitis, you will have fever where you are suspecting staphylococcal infection, but not in tracheobronchomalacia. Tracheobronchomalacia, it is a sonorous wheeze and the child may have retractions.
Dr. Asha Prakash Mohapatra from Cuttack, he wants to know the rationale behind the use of normal saline nebulization and 3% normal saline nebulization. Is there any clarity on it?
When there is hypertonic, 3% is hypertonic saline. So it's supposed to reduce the secretions because of the absorption. So if you do not have access to 3%, you can use normal saline, but 3% is what is recommended, as it will reduce the secretions because of the hypertonicity.
Okay. We'll take 1 or 2 questions more, then we will have to end this session. Dr. Babita Khanal from Dharan wants to know, if a child is wheezing and there is a history of bronchiolitis in past, the wheezing is always associated with flu symptoms. Should we treat the patient as asthma or just treat for the episode symptomatically?
See, it's a good question. As I told you, the phenotype of the under 5 WHEEZER will vary from time to time. If you are assured of a regular follow-up of this child. If you are convinced that this child has a wheeze only when it has a viral respiratory infection, in between the episodes of viral respiratory infection, we are not having any symptoms, then oral or inhaled bronchodilator alone will do. On the other hand, you have been treating the child from a very young age, you find that the number of episodes of wheezing are on the increase, or the child has some atopic dermatitis, or there is a family history of asthma. If the number of episodes are more than 3 in a season, there is nothing wrong in adding a low dose inhaled corticosteroid in this child, as the phenotype is shifting from episodic viral WHEEZER to a multi-trigger WHEEZER.
Dr. Anil Khanal from Gandaki asks, can salbutamol be used in children less than 3 months?
That is what? Initially, we thought that the beta receptors are not well developed in these children. In a very young infant, a levosalbutamol will be better than salbutamol because the tachycardia, it is more cardio-friendly. The problems with salbutamol can be tachycardia, tremors, and increasing hypoxemia because of the VQ mismatch. So a levosalbutamol will be a better therapy for inhalation compared to salbutamol in a very young infant. If a trial gives relief to the child, there is no harm in continuing that.
This is the last question we'll take. It is related to cystic fibrosis. It's a research question. Dr. Sahajram from Roorkee wants he says that I have learned one online journal. They mention azithromycin dose regimen on specific days like Monday, Wednesday, Friday in cystic fibrosis. Is there any specific reason behind it?
See, the common organisms that infect a child with cystic fibrosis. In cystic fibrosis, the secretions are thick and the Pseudomonas colonization is one of the reasons why a child with cystic fibrosis deteriorates. It gets admitted for repeated pneumonia. And these Pseudomonas can form an envelope around themselves and make the antibiotic not act. That is why we use antibiotics like piperacillin, tazobactam in admitted children and ciprofloxacin in other children. Azithromycin is capable of dissolving these around the organism, and they also help as they have an anti-inflammatory effect. That is the reason why azithromycin has been used for follow-up in these children.
Yeah, last question I think we will take. Dr. Revati Govindarajan from Pune asked, persistent rhinorrhea in an infant under 1 year of age, how to go about if the child is otherwise normal? There is no history of atopy, no family history of asthma and allergy, and growth is normal. The only problem is persistent rhinorrhea in an infant.
I think we have to treat it like a perennial allergic rhinitis. Allergens of avoidance, recurrent washing of the bed sheet, linen, pillow covers, these are all very important. There is nothing wrong in young infants in giving a bedtime antihistamine if it is going to be many of the second and third generation antibiotics, which antihistamines, which were not recommended in young infants previously. Nowadays, they are recognized for use in young infants. So there is nothing wrong in treating a child with a bedtime antihistaminic.
Dr. Pradeep Bhattarai from Gandaki asked, sometimes pediatricians use the term reactive airway disease. How correct is this? Or we just say hyper-responsive airways?
Even Nelson uses the term. The latest edition of Nelson, I was very happy because when I see a child first in practice, and I'm not able to come to a conclusion because that's the first visit that I've seen, a child has got wheeze. I put it as hyperreactive airway disease. If there is a family history or a personal history of atopy, and I find on follow-up, this child has even wheezing in between the episodes of respiratory infection, then I term them as multi-trigger wheezer. So it is all, no, God never gave a disease its name. Only man started giving names for diseases, like we have given COVID-19.
Yes.
Coronavirus doesn't know that it has been named as the disease has been named as COVID-19.
Yeah. Just one question, because you talked about COVID. When the doctor has asked, is the COVID diagnosis grave in asthma and COPD patients? Any personal experience or what you have seen?
By God's grace, COVID incidence is low in children. So far in Tamil Nadu, only 33 cases of children are reported. None of them have been admitted and no admission into the ICU. And I have no personal experience of treating any COVID-19 patients in the last 1.5 months. But fortunately, even when you take the world literature, only less than 2% of the children are affected and only 0.6% of the total have required acute care.
Okay. So Dr. Vadarajan, excellent talk, and you have been very kind to answer almost. You have covered all the questions which have been posed by the participants. Thank you very much on behalf of the Alembic team and all the participants in today's pediatric expert opinion. I convey my warmest thanks to you, and I conclude the session.
Thank you, Dr. Abhijit.
Thank you all for the participation.
The meeting in such a nice way, and thanks for all the participants who took their time off and spend the last 1 hour and 10 minutes with us.
Thank you.
Thank you.
Thanks.